The New Zealand Royal Commission Lessons Learned. The New Zealand Commissioners have requested information regarding the use of vaccines to manage COVID-19, the use of lockdowns in 2021 and 2022, and information regarding testing, tracing, and related matters. The Physicians and Scientists for Global Responsibility New Zealand, PSGR, took an active interest in COVID-19 and COVID-era decision-making and the scientific bases used to justify policies and laws throughout this time. PSGR's primary concern was the protection of public health. Key to this would be a whole-of-government pandemic response that was proportionate to the threat presented by this infectious disease event. A century of public health science informed us that the threat would change depending on the season, when the virus was circulating, the immune health of the individuals, the timing of circulating strains, and the extent of natural immunity present in human populations. The Health Act 1956 was the tool that was enabled for officials to set in place the emergency powers. Astonishingly, officials chose to ignore Part 3 of the Health Act 1956. This section, Part 3A, outlines the obligations of officials in an infectious disease event. It requires that the dignity of the individual must be respected, that all measures must be proportionate to the public health threat, and that the least restrictive alternatives must be applied. Historically, the threat of a pandemic revolved around population risk for hospitalisation and/or death. In 2020, the Office of the High Commissioner for Human Rights stated that the suspension or derogation of certain civil and political rights is only allowed under specific situations of emergency that threaten the life of the nation. Central to achieving a proportionate response would be a capacity for dissenting and contradictory scientific views to be presented and debated. Pandemics are dynamic, rapidly changing events. The science of public health is dependent on what we know now. Therefore, it is in a place of challenge and debate that something approximating truth will emerge. In May 2020, the Attorney General's overarching COVID-19 Public Health Response Act was passed overnight without public input. Contradicting any requirement of proportionality, the COVID-19 legislation would revolve around prevention of transmission of infection, whether or not that current strain of infection presented a risk of hospitalisation and death. Our legislation would henceforth focus on chasing the case of infection, and later driving vaccine take-up, no matter the risk of hospitalisation and death. Although commissioners wish to focus on 2021 and 2022, early government memos and policy statements set the scene for policy through the constant repetition of a future safe and effective vaccine. It was inferred that a vaccine would prevent hospitalisation and death. This would never be proven. The psychological literature could have predicted that the repetitive internal messaging of safe and effective would usher officials to focus on a single injectable, even if it was scientifically and ethically unsupportable. It could be predicted that this constant messaging would later leave officials on the back foot and defensive should any data contradict the safe and effective expectation. Many papers communicated that COVID-19 predominantly presented a risk to the elderly, the infirm, and/or extremely multimorbid, much as seasonal flu would. Independent research from 2020 to late 2021 consistently reinforced this finding. This information was reinforced by case studies from contained or enclosed environments on military and cruise ships. Cruise ships contain a high proportion of older adults, the cohort most at risk from COVID-19, the illness. The scientific evidence by mid-2020 strongly suggested that COVID-19 did not and would not threaten the life of the nation. COVID-19 presented an equivalent threat of serious cold or flu to the majority of the population. Yet this scientific evidence was excluded from government white papers and was ignored by the media. Evidence was muddied as institutions where researchers had financial and political conflicts of interest produced data and undertook modelling that would fail to address the case fatality rate by age and gender. Often this data, because it harmonised with the existential risk messaging, was uncritically accepted. Early 2021 is an important time. February-March 2021 was the very time that the New Zealand government locked in the vaccine rollout plan. Henceforth, all of government resources were committed to the staged rollout. No resources were committed to evaluating and re-evaluating risk by age, gender, and health status from the coronavirus, SARS-CoV-2, or the Pfizer biologic injectable. However, also by February 2021, Pfizer's post-marketing data showed that the gene therapy vaccine, a biologic, did not prevent death, and it resulted in a spectrum of adverse events that resulted in outsized risk by age and gender. This information was held by the US FDA in February 2021, and we can only presume that New Zealand officials were similarly briefed. It was clear that the vaccine's efficacy quickly waned and that it could never be depended on for the most at-risk group, the immunocompromised. Immunocompromised people were underrepresented in the trials. Despite this, ministers, ministry officials, and officials in the Crown Law Office created a cascading series of policies, laws, and regulations that revolved around high vaccine take-up to reflect the stages of the March 2021 rollout plan. As each tranche of secondary legislation was enacted to tighten vaccine mandates, the ministers and officials did not. They failed to consider risk by age, gender, and health status from either the SARS-CoV-2 infection or the Pfizer BNT162b2 gene therapy. Biologic drugs are produced in living systems rather than by purely chemical synthesis. Pfizer, the Ministry of Health, MedSafe, and the NZ-EPA knew that the mRNA was the active component of the vaccine and that it was unable to self-replicate, but was translated into human cells to produce the SARS-CoV-2 surface glycoprotein, the so-called spike protein, which was intended then to generate an immune response in recipients. Contamination from residual DNA is mechanistically expected by manufacturers at trace levels and can remain after manufacturing. Pfizer sought registration of a biologic entity, a biological entity. Yet in the new medicine application, Pfizer ticked the box for vaccine. It is uncontroversial to state that Pfizer always knew that the biologic BNT162b2 gene therapy was a risky product prone to contamination. Because gene therapies are a brand new technology, the residual DNA contamination dose limits were based on theoretical risk modelling. And DNA contamination risk presents an oncogenic cancer risk. Yet, because the application was for a vaccine, it would evade the mutagenicity and carcinogenicity testing required for biologic and standard medical products. This is extraordinary. A product that directly alters cell function, that carries an oncogenic risk, will directly increase risk for cancer. Medical doctors are trained to accept and recognize that medical drugs will always carry some element of risk. This is why the practice of informed consent is entrenched in medical education and reinforced throughout the professional life of a doctor. And this, again, is non-controversial. Yet, if medical doctors raise the issue of risk of the Pfizer BNT162b2 gene therapy, they directly risked losing their medical license. In October 2021, Minister Chris Hipkins' COVID-19 Public Health Response Amendment Bill number 2, the bill that would lead to the expansion of powers from November 2021 onwards, was published for public consultation. That number 2 bill was in place to ensure that the February-March rollout plan would not be hindered. The public were granted 11 days to respond. There was an avalanche of a response, and nearly 15,000 people submitted to that bill in that short time. Hipkins had published the number 2 amendment bill, which did not discuss vaccination. This bill smoothed the path for mandates. So people that expressed concern for vaccines and mandates in their submission to the bill were dismissed in the departmental report that was carried out for the select committee because their concerns did not speak directly to the bill's text. So the health committee relied on departmental report, and that dismissed the concerns of approximately 14,000 people because they did not look at the content, and they spoke outside the scope of the bill. So they only considered the content from 1,000 people. Please understand, Royal Commissioners, that at precisely this same time, Chris Hipkins' number 2 bill was underway. Chris Hipkins was busy drafting, with the Crown Law Office, the COVID-19 response vaccinations legislation bill. This bill mentioned vaccines repeatedly. So despite the public outcry, Hipkins' amendment bill number 2 would be passed 9 working days after royal assent was granted to that number 2 bill. Hipkins' vaccinations legislation bill was presented to Parliament. The bill was secretly passed the day after, on Saturday the 25th of November, and it was immediately integrated into the 26th November version of the overarching COVID-19 Public Health Response Act. The next tranche of secondary legislation would vastly expand and tighten vaccine mandates. The Honourable Chris Hipkins had released 3 more orders on the November the 29th, December the 1st and December the 3rd altering the definitions of a vaccine concerning record keeping and locking in COVID-19 vaccination certificate, CVC requirements to access certain places to receive a service. So by one working week, the 4th of December 2021, these orders had completely altered the COVID-19 Public Health Response Act. This was not a fair and just playing field. Summer 2021-2022 would be the summer of injection to access cafes, workplaces, services, and government institutions due to Hipkins' intentionally sequenced legislative output. Over this same period, PSGR published a series of information pages we submitted to the Health Select Committee on the No. 2 Amendment Bill, and we corresponded with the Children's Commissioner and the Coroner. PSGR were concerned that officials were overpromising efficacy and downplaying risk for this biologic technology. We were aware that the disease COVID-19 could present in complex ways, depending on the particular physiology of the individual. We were aware that nutrients to lower risk of severe respiratory disease had been downplayed by governments and were increasingly aware that generic drugs with a long history of safe use were being suppressed. In October 2021, the PSGR drew the Health Select Committee's attention to the importance of policy formulation for effective state management of pandemic viruses and the necessity for individual approaches due to individual vulnerabilities. We emphasised the importance of adequate endpoints for, as the Health Act demands, the protection of public health. It is fundamentally important to recognise that the pandemic emergency response was predicated upon a scientific claim that infection from SARS-CoV-2 created the symptoms attributed to COVID-19, that they would be so devastating that without a swift systemic response, there would be massive harms to human and economic health. Hospital systems would be overwhelmed. The trauma would be horrendous. But the safety and efficacy of the Pfizer-BNT 162b2 gene therapy would also rest upon scientific claims. Secondary legislation does not require parliamentary oversight or parliamentary approval. And during COVID-19, it was produced in secret. There were no methods-based analyses to understand the relative risk ratio with every new tranche of secondary legislation to demonstrate that it was warranted. Ministers, health officials, and officials in the Crown Law Office did not balance the risk to the average person by age, gender, and health status from either the SARS-CoV-2 infection or the Pfizer-BNT 162b2 gene therapy. They simply harmonised to the pre-established, predetermined 2021 rollout plan that had been designed some 6 months earlier. If we turn back to the Health Act 1956, the paramount consideration of this Act is the protection of public health. Sadly, the COVID-19 Public Health Response Act and the reams of secondary legislation that it spawned enabled ministers and public officials to derail and ignore the globally recognised principles and precedents that were in place to protect people from government overreach, in addition to those infectious disease principles in the 1956 Health Act, Part 3A. UNESCO's Universal Declaration on Bioethics and Human Rights emphasises the protection of the individual. It was ignored. Medical practitioners' capacity to practice informed consent was kneecapped by threats from the Medical Council of New Zealand that they would be reported if they did not harmonise with policy. A key pillar of historic pandemic management, the recognition that as waves of the infection roll through the population, people will develop natural immunity and that this will curtail the virulence of the infection, was ignored. Teachers and healthcare professionals are conventionally the first people to achieve natural immunity and henceforth are some of the safest people to care for the infirm and vulnerable. Yet this century-old knowledge was disappeared from public communications. The central focus on infectivity and infection rates, the blanket injection of the population, and the rejection of natural immunity was an extraordinary deviation from historic pandemic management. The Bill of Rights was set aside, and human rights to freedom and the human rights to health and to deny a medicine were set aside. Medical ethics were dismissed and informed consent was ignored, and in fact, no bioethics consultation was ever undertaken in New Zealand. There was no proven safety process because this biologic injection had never been injected into human populations before. It was incorrectly implied to act similarly to a conventional vaccine. It is now widely understood that the COVID trials did not evaluate whether the Pfizer BNT162b2 vaccine prevented hospitalisation and death in older and high-risk people. The trials did not evaluate whether the BNT162b2 vaccine prevented the risk and prevented the spread of infection. These were the endpoints that most people believed would have led to the release and mandating of a previously untested biologic gene therapy. Instead of standard 3-year and more trials, the FDA permitted Pfizer to terminate the BNT162b2 study after 6 months and then offer the vaccine to placebo recipients, muddying the trial. The public were misled by the claim of 95% efficacy. It was not communicated that efficacy merely meant a short-term reduction in infection. COVID would continue to circulate, and it was very clearly recognised that the vaccine waned very quickly after injection. Post-market safety monitoring was poorly executed, and Pfizer's troubling February 2021 data hidden by New Zealand officials. The New Zealand EPA declaration that BNT162b2 was not a new organism failed any appropriate peer review. This was a brand new biologic drug. Biologics manufacturers have struggled with contamination for a long time. This well-established risk was never discussed, and shockingly, batches were not routinely tested to evaluate total contaminant levels, even though Pfizer recognised how inexpensive it was to batch test. There was no transparent and published testing in New Zealand to assess the extent of spike protein produced by age, gender, and health or multi-morbid status, including by immunocompromised groups, despite the fact that this was a biologic drug that would send the instructions to the cells to reproduce that spike protein. There was no testing to assess the length of time that a body would reproduce this known to be thrombotic spike protein. There was no testing to assess the inflammatory potential of the spike protein in New Zealand, either in healthy population groups or in heavily boosted populations. New Zealand's science system is not and was not conducive to the publication of contradictory information. The Department of Prime Minister and Cabinet, the DPMC, controlled the funding for research into modelling of the SARS-CoV-2 virus and its future variants, yet the DPMC was focused on the vaccine rollout. PSGR understand that MB was heavily involved in the initial vaccine contract negotiations. But MB also controlled science funding. And then MB controlled the information that would be reported to the Health Select Committee from those 15,000 public submissions to the number 2 amendment bill. MB had extraordinary power over the production of information that could contradict the vaccine rollout. All government institutions with research capacity were committed to the April 2021 rollout goal. Commissioners, MB was a partner to this event. MB controls science funding. There is no funding route for any scientist in New Zealand to undertake research on the safety of the Pfizer BNT162b2 gene therapy, and there still isn't. The combinatory power of the DPMC and MB's control over the scientific and technical information produced in COVID-19, plus the swift response of the media to curtail and shame practitioners and academics who spoke out, contributed to the vast institutional silence. And grievously, the scientific evidence on what risk constituted was ultimately handled by a very small group of people. PSGR are aware of large numbers of people with scientific medical expertise that sent in information to members of parliament, to the amendment bill, to Pharmac and MedSafe, that the cure was disproportionate to the cause and that it waned and threatened harm. And broad swathes of scientific information sent to officials and parliamentarians have essentially been buried. And alarmingly, the coroner has had no resourcing nor powers to determine whether a death was caused by infection or comorbidity, nor to assess vaccine-induced injury. Judges exhibited no curiosity in demanding independent assessments of risk from COVID versus the gene therapy injection by age, gender, and health status, but deferred to the Ministry of Health, who was preoccupied with the April rollout plan. The courts misapplied the precautionary principle to claim that people should be injected, and privacy was sidelined because of the obligation to prove vaccination status. There were social, political, and medical barriers to submitting adverse event data. Pharmacovigilance failed from early stages, with doctors recognising that vaccine scepticism could result in their being politically and professionally ostracised and even professionally sanctioned. The policies, laws and regulations and the control of legacy media acted systemically to form a networked grid of power that compelled the population to acquiesce to the pharmaceutical and non-pharmaceutical interventions, no matter the age, gender and health status and personal belief of a person. The grid created extraordinary and unprecedented barriers for experts who sought to question or contradict the mainstream language and messaging. It is probable that the New Zealand commissioners are grappling with extraordinarily politically uncomfortable facts. And what is surfacing is that the COVID-19 response amounted to an extraordinary overreach of executive and parliamentary power. And this was enabled through the scientific claim of a global emergency, the self-empowerment of elected officials, and the fast-tracked legislation under the guise of an emergency, and the propagandized harnessing of media and information systems. The government used the traffic light policy to herd people towards vaccination, and proxy processes, including COVID vaccine certificates, to avoid direct mandates and claim that people had a choice in being vaccinated. As this paper has emphasised, risk in the Primary Act revolved around the risk of spreading infection, not on hospitalisation and death. The legislation that was critical to framing risk was predominantly produced in secret, and the science system did not permit the production of contradictory information. Commissioners, if you are to act justly and fairly, you must patiently sift through the contradictory evidence consistently produced by scientists and officials from February 2021 and evident by February 2021 that SARS-CoV-2 would never threaten the life of the nation. Institutional and corporate secrecy, cabinet privilege, the secrecy of the Crown Law Office, the secrecy of Pfizer's contract, and Pfizer's and MedSafe's adverse event data is a devastating legacy of the COVID-19 pandemic. And the introduction of a new technology using emergency powers is a frightening precedent. Although PSGR has a 20-year history of research into health and genetics, we are yet to be asked to present personally to the commissioners. We thank you for listening.